Hi, and welcome to our weekly podcast. I'm your host, Brent Dodge, and I have with me Angela Listag-Vapp. She is our clinic manager of Alpine Physical Therapy North, and she's here to talk to us today about shoulder instability. Angela, we're glad you're here.
Thank you.
You know, I'm sure our viewers are wondering, what is shoulder instability? Can you help define that term?
I sure can. Let's start with what stability is. The shoulder is actually a ball and socket joint. And a joint is where two bones meet each other and movement is created. The shoulder has a socket and it has a ball, and so it's a ball and socket joint. A stable shoulder, when we move our arm, the ball will stay right in the center of the socket no matter what we do. Instability is when that shoulder, or when the ball doesn't stay quite in the socket and then it irritates and annoys structures around it as we move. That irritation can cause inflammation in those structures, and it can also just impinge structures, causing pain.
So an instability is really anything where that ball is not centered. It can be moving around from a lot of different causes, a lot of different reasons.
It can be a large instability where you actually dislocate and the ball comes out of the socket. It can be very subtle instability where it might just move a little bit extra.
Well, what makes a shoulder stable or unstable?
I like to think of joint stability in this way. So there's three things that give us joint stability. One is going to be what I call active stability. And active stability means that it's the muscles, and it's the muscle strength that helps keep that ball in the socket. The other stability is passive stability, and this means the passive stability means you can't actively do anything about it. This is just going to be the structure of the joint, so our anatomy, our bony anatomy. And for the shoulder, you have a very small socket and a relatively large ball. So it doesn't have a lot of bony stability. Then you also have other passive structures that help. That's going to be the ligaments, and the ligaments go from one bone to the other. So for example, if you put your finger across the top of my hand right here, that could be a ligament. And let's say if I went this way, it would only let me go a certain direction or a certain distance before it stops. And so that's a passive stability structure. And then there's a third area that gives us stability. It's called neuromuscular control. And this can be a little more complicated to understand, but in a simple way, our joints have little receptors in it that send information up to our brain about where our joint is in space. And our brain processes that information and then decides what it wants to do with it, sends information to the muscles around that joint to react. And so you can think of neuromuscular stabilization as reactions. Does that help?
Yeah, I think that's going to be great. So it sounds like there's more than just one piece to the instability puzzle.
There is.
If it's muscle, it's ligament and bony structure, it's the nerve connectivity.
Exactly. So if there's a default in any one of those areas, you can have instability. And it can be subtle, remember, or it can be large instability like coming out of the joint.
What are some of the things people might feel if they're wondering, you know, I've had some shoulder problems, do I have an instability? Are there things they might sense or feel?
There are. And instability can be easy to uncover, or it can be very difficult. People that would have impingement type pain, and usually that pain is on the top here, it can be from a couple reasons. One of those reasons can be instability. And for example, let's say you're lifting the arm like this, and if everything is intact, all the muscles are working together, the passive structures are all intact, and your brain and your shoulder are talking to each other well, you're going to move that arm up, the ball is going to slide down in the socket so it stays centered the whole time, and it's going to clear all the tissue above it. Now if you have some sort of problem in the muscles or the passive structures, maybe your ligaments are too stretched out or you have a little tear in the muscle so it's not as strong, you might, instead of glide down like this, you might actually roll up, and look what you're doing, you're pinching your tissue. So instability can present just like a shoulder impingement, which is just pain here. It can also have characteristics like a little bit of extra popping or cracking. It can feel like a giving away or a weakness. So it can be subtle like that, or also, just blunt dislocation. You know that.
That one's probably a little easier to figure out.
Yeah.
Wow, so that's great information for our viewers, I think, to have a sense of what might be going on. But one question they may be wondering about, is there anything that a physical therapist can do to help with this problem?
Yes. Physical therapists can teach you how to do exercises that will affect any areas of those instabilities. Usually instability happens when we have a problem in the passive structures, the things we can't do much about. And so a physical therapist can then help you learn how to strengthen the right muscles and also give you exercises to address that whole reaction I talked about before, the neuromuscular control. I think the neuromuscular control exercises and activities is what makes shoulder rehab a lot of fun.
Are there specific exercises that you could define for our viewers?
Definitely. One might be a hands-on technique, and it's called rhythmic stabilization. And the person would be lying down on their back, and they might have their arm in various situations or positions, and the therapist would start to give perturbations to the shoulder. And what this is going to do is teach those reactions and how to improve those reactions. You can vary this activity by having them close their eyes and then also put their arm in different positions. Another exercise that doesn't require a therapist at all is a ball on wall exercise, where the person is putting their hand on a ball on the wall, so slightly unstable surface, and then doing circles. And again, you can do this standing with your eyes open on an even floor. You can do it in an unbalanced situation, which makes it more difficult and harder for your shoulder to react, but teaching that skill. And then you can do it with your eyes closed on an unbalanced situation. So again, this is where rehab can be fun.
Something our viewers may not be aware of is that Angela is a residency-trained orthopedic manual physical therapist who completed her residency with the Kaiser Hayward program, and that was in San Francisco?
The Bay Area.
The Bay Area. And one of the parts of that program, which is a 9-month residency training program, was for Angela to write a paper, and she's done so. And Angela, if you could describe that paper for us.
The paper is probably directed mostly to physical therapists, and it is reviewing the current literature on shoulder instability and rehabilitation. So its main focus is that whole third component I talked about, that neuromuscular instability, and how a therapist can affect instability in a positive way.
If you'd like that information and want to access that paper that Angela has written, you can go to our website and go to the health information section and locate that document. But right now, I think Angela has a tip of the day.
Here's your tip of the day. Think of your PT exercises as pain management, just like you would think of your pain pills. When shoulder instability is your problem, often performing a set of your exercises that the PT described can actually get rid of your pain for a while, and the cumulative effect can get rid of your pain completely.
I'd like to thank Angela for taking some time and giving us some valuable information on the topic of shoulder instability. For more information, visit our website or call our clinics.